Good morning. Andy Hahn, great talk. One of the best I've ever heard on the topic. I think that you put up very quickly the Juanita-Crook study, intermittent versus continuous ADT. And I sort of think we buried the lead when we talk about that trial. Because if you look in the subtext of that trial, the patients who were on intermittent hormone therapy were more likely to die of prostate cancer. The patients who were on continuous hormone therapy were more likely to die of cardiovascular disease. Possibly, probably, treatment-related from being on continuous ADT. So I think the real opportunity with metastasis-directed therapy is not that we're going to cure more men of prostate cancer, although we might, but what we might be doing is avoiding for them a cardiovascular death from the treatment that we're giving them, right? And what we really need is a trial that sort of puts that to the test. And I'm not sure there's one up and running at this point in time, but I think your points about optimal duration of ADT during metastasis-directed therapy are really good. And I'm just wondering if you could restate sort of your approach when you talk to patients about when you're putting them on ADT with metastasis-directed therapy, about how long you're going to treat them.
Yeah, okay, all really good points. I think we think through this very similarly too. I think you highlighted one clear unmet need, which I feel like is to date, when we talk about precision oncology, we're focused on tumor intrinsic variables, right? Like how do these alterations influence who's going to respond or not respond? But the other component is who's going to wither away or potentially die from harms of hormone therapy, like the precision oncology focusing on the host factors. And we haven't done that, and I think that's like a wonderful plug for the need to do that, because if we could do that, then you may better be able to stratify who should go on to get metastasis-directed therapy up front, or finite hormone therapy up front, or some combination of the two. And I think because the other challenge, like I think, and I'll slightly call out the radoncs in the room here, like I highlighted that patient from Colorado because that guy's done wonderfully for 2 years, but like he is very upset on the whole because his quality of life it got destroyed because of complications of radiation plus hormone therapy, like an aggressive approach. And so just to say, I agree with everything you said there. I think when you see a patient who has BC, like for how do I do it with patients? When I see a patient who has BCR/oligometastatic disease by PSMA PET after salvage radiation, I take like 5 minutes at the beginning of the discussion to just try to reframe the disease for them and reframe it that like we are now dealing with a chronic disease like diabetes, like high blood pressure, that you will intermittently deal with for the rest of your life. But my treatment, if I just focus on PSAs of 0, which is so easy to do with patients, like the easiest thing is just to walk in and say, hey, ADT plus AR pathway inhibitor, your PSA will be 0, you'll be happy.
Exactly.
But then if you get people on board, like if you spend 5 minutes, they're okay with it. I mean, there's the few that I have issues with, but when I do that, and then I say, hey, we're waiting for PSA doubling time to hit certain levels, PSAs to hit certain levels, we're going to get PET scans, then we'll figure out what's the right approach from there.
I call that the existential moment for a prostate cancer patient when they realize that the surgery didn't cure them, the radiation didn't cure them, and now it's with them for the rest of their life. And prostate cancer is a part of the rest of their existence, and it's a reframing. I like how you put that. So there's a lot to learn. I think of metastasis-directed therapy as almost a survivorship question, right? Which is how much hormone therapy is this person going to need for the rest of their life, and how can we minimize that?
I'm gonna make a comment because I think a really important trial was not mentioned at all. That's the PSMA DC trial. So PSMA DC is delayed castration for the DC. It's oligometastatic disease, and it has to be conventional imaging negative. And then the randomization is not to hormones, no hormones, because most men don't want hormones. How about randomization to lutetium, no lutetium? And so that trial is a phase 3 trial. It's underway right now. It's up in about 65 centers globally that include both Europe, Australia, and US, and Canada, and Japan. And I think it's a really important trial, but nobody mentioned it. So I want the defense of the no mention.
I don't have a good defense for not mentioning it. My apologies for that. I think like to both of your points, and I think it's, as medical oncologists, we're going to have to grapple with a new way of thinking about how we approach the disease and what endpoints we care about. I mean, we've historically been obsessed with OS and PFS and showing Kaplan-Meier figures, but if we only focus on that, whether it's using lutetium, which has its own unique lung toxicities, or whether it's radiation or hormone therapy, I think we have a tendency to under-reporting the long-term harms that come to patients. And I think we just have to kind of grapple with that as a community. And I think you can even, I have this slide that I'll oftentimes show. It's a bit misleading, I'll acknowledge, but I put up the SEER data from 2010. I put up the SEER data from 2023. And while despite all of our advances in technology, there's more deaths in 2023 than there were in 2010, and the percent is right the same. And that would argue for exactly what Chuck is saying, which is you gotta balance the harm to the patient versus treating the cancer. And I think interpreting lutetium PSMA monotherapy is going to be that same thing, because like, what's the long-term ramifications?
Okay, now it's a couple of issues. So first of all, it's not lutetium monotherapy, it's metastasis-directed therapy plus or minus lutetium, MFS endpoint. The only phase 3 trial in this space. Everything else is phase 2, only phase 3. I want you to keep an eye on it, because there are a lot of men who don't want to be castrated. And if this trial is available in your space, please offer it to them, because it's a really good trial. Novartis-sponsored phase 3 global trial underway.
Hi, this is Mira Keys from Vancouver. So I'm one of these oncologists who actually were putting the patients in PR7 and PR8. I just wanted to address your question, and the question really was, what do we do with all of these patients that actually die on ADT, right? So on one hand, it is helpful. On the other hand, really, there is a devastating side effect, which is a death. And so I just want to remind people there was a pronounced study that looked at agonists versus antagonists, right? And to our kind of dismay, the study was negative. However, all of the patients on the study were actually managed by cardio-oncology. And I think this is the underlying message of the study. So you're safe to give hormones to save lives, but you have to manage cardiovascular disease. And we are not, equipped and knowledgeable to actually do that in patients who really have quite significant morbidity. So I just wanted to remind people of that.
I wholeheartedly agree, and that's my spin on that study as well. So wholeheartedly agree.
So changing topics. Can you guys hear me? If not, I'll yell. Is this working? Great. So changing topics a little bit, going back more to the biochemical recurrence after surgery space, and kind of avoiding over-treatment of either early salvage or salvage therapy, is that there's a dichotomy that exists here, right? Is that we do know that if you intervene early, when you have an absolute PSA value that is lower, patients do better. If you have a negative PSMA scan, versus those who have positive AVID scans, those patients are going to do better. So how do we balance all that, right? Who gets that actual treatment? Who do we choose to observe? Is it solely based on PSA doubling time, and then you're happy and you say, well, you're never going to have a problem? Obviously, there's other factors, comorbidities of those patients to take into account, but just clarify what your practice is. Are you going to not offer that patient early salvage or salvage therapy? And be so reassured that they'll be fine because they have a low PSA and a negative scan.
Well, I think that's the biggest challenge for us. We follow the PSAs, and if the PSA is starting to rise after definitive therapy, you get a scan, and the scan's negative, then you're forced with the dilemma of having that discussion. And I tend to be more conservative, and I will follow those patients closely and then bring them back and then maybe rescan them if the PSA continues to rise. That's really the way I've tried to manage those patients, but you're right, the data really supports if you treat earlier, they're going to do better. So it's a dilemma, and you just need to have a hard conversation with the patient and find out what they want to do. But I think that's the line of thinking that I try to follow when I manage those patients. Christian.
Well, yeah, despite all my talk about the low risk and the high risk recurrence, and the guy's PSA is 0.2, 0.3, they're going to have a negative scan, they're going to see the radiation oncologist. Like, they get the referral, those guys have the complex conversation, not me typically. That's just how it is. I think most of them end up getting radiation, because they want to see that PSA go to zero, as was alluded to. There's a comfort there. And there's also the discussion they get that, don't worry, you won't be on lifelong ADT. We might use it during the salvage treatment, but not lifelong. There will be other options if things come back. So I don't have the conversation myself often, unfortunately. I do try to hold out and, like I said, not get the PET scan at, a PSA of 0.12, but I think that's what you were asking.
One of the things I think that is problematic is the fact that the PSMA PET's not sensitive enough. We talk about the huge change from the conventional imaging to the PET, but there's another generation of PET scans that are coming. And there's the copper scans that are probably going to take the sensitivity down yet another notch. I just got back from Australia, really, really provocative work with some of the newer scanners and using a really rapid uptake, sounds almost paradoxical, but looking at 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 minutes. So the injection, and then you literally do like a video. And these early uptake lesions are, by the way, subject to false positives because you'll have some inflammatory areas. But then you see the uptake, and then you have a washout. The benign lesions are more likely to wash out. If there's a retention, they're more likely to be real. And so there's really cool stuff coming, hardware, software, new imaging, that I think will change the threshold at which we call positivity. But anyway, just cool stuff coming.
That's still, I think, at least a couple of years away, I think, still. I think, I think the horizon's bright. I mean, look at where we were with flucyclovine in 2016. I mean, it's been less than 10 years, and look at where we've come. And I agree with you. I think we're moving forward.
So the copper clinical trial, phase 3, recurrent disease, starts in April. And I'll stop and talk to the Clarity people if they're here. But that's clinical trial will accrue very, very, very rapidly and likely be better. And then the actual imaging with the software, hardware, the time things, it's actually available today. There are 32 centers in the world that can do it today, but I think there's only 2 in the United States.
Can I just one comment to kind of bring the BCR and the metastasis-directed therapy conversation together? I found that, there's a fascinating study 10 years ago, this Herculean effort by Steve Bova and a whole consortium that looked at a bunch of men who died of androgen, insensitive, metastatic, castrate-resistant prostate cancer. They, analyzed the metastases, the primary prostate, every bone lesion they could find, and basically the outcome was, my God, the natural history of the evolution of lethal prostate cancer is that cancer goes from the prostate to the metastasis, from the metastasis to another metastasis, back from that metastasis to the prostate, somewhere. So every site can metastasize to everywhere, essentially. And so going back to, I think, Dr. Hahn's talk, correct me if I'm wrong, there was some indication that you have some patients that you would observe normally. A PET scan shows one speck, in a bone somewhere, maybe a speck in the other bone. The PSA is not going crazy, and you'll observe these guys. And as a urologist, I'm thinking, my God, he's got a spot on that rib. It's hot on PET. That could metastasize somewhere else. What's the harm of a little SPRT there? So tell me about how you put into context the idea that these Mets are actually dangerous. There are probably more. We'll get more sensitive scans. But there are men who literally, there's one hot spot, the PSA is 0.4. It's probably coming from there. Why not zap it, I guess is my question, and then avoid the hormones long term?
So it's a good question. I think it's, in my mind as a medical oncologist, mostly dabbling in hormone therapies, I think it's that shift that's happening. Like when you shift a patient into metastatic disease, we start thinking, oh, we're going to be treating you a lot for a long period of time. And I think there's this desire to try to avoid that as much as possible. Now, where I have hesitation of just jumping straight into metastasis-directed therapy alone is, in my experience, there are harms that come with metastasis-directed therapy or potential harms. And it's not clear when you have a one-time snapshot of a PSMA PET CT. Like, we know that we're going to have more sensitive tests and we're going to find more things, most likely. Like, that's just the natural history. We went from conventional imaging to PSMA PET. So is that the tip of the iceberg, or is that the driver? And I think that's like the underlying question, and it's just a huge unknown there. And until, in my mind, like, we have something that actually directly compares head-to-head metastasis-directed therapy followed by, later initiation of ADT versus some version of intermittent or continuous ADT. That's like, I think, when you have true comfort of using metastasis-directed therapy first. Otherwise, I'd rather try to let things settle out. And then if I'm going to, my interpretation of the data is, and I hear you guys, I guess this is me being a medical oncologist, but my interpretation of things is like, intermittent ADT was our standard for the longest time. The EXTENS trial clearly shows doing metastasis-directed therapy improves things. So my hope is that if I hit them hard for a short period, I can really reset the clock for a long time instead of just zapping that spot and then coming back to my clinic 6 months later and another spot popped up and another spot popped up. But I think what we really need is something that tells us, that metastasis is actually the driver of their long-term outcomes versus that metastasis is just one of many.
But the question then for you is, what's the harm of a kind of delayed series, right? So if you went and did metastasis-directed therapy, watch for the response. If something pops up, then you're like, okay, now you've already selected yourself for having worse disease there. That's when you start doing the more systemic therapy.
And I think that's totally reasonable. Yeah. I mean, I'm not saying that's unreasonable. I think that's reasonable.
So it didn't get a lot of discussion. Show the EMBARK trial is a provocative trial, but did not use PSMA PET. And one of the things with the EMBARK that was a little bit surprising to me, if you look at the PSA cut points at which the efficacy was present, it wasn't 1, 2, 3, 4, and 5. If you looked at a PSA of 10 or even up to 20, in their 10 to 20 range, the actual efficacy was similar. So the idea that you have to treat with hormonal therapy immediately, and I'm going to call it the EMBARK era, I think is not necessarily true. You can do your SBRTs, you can try the metastasis-directed therapy. If they're rapid relapsers, then you have a systemic backup that'll probably be effective. So, I in my own practice, I'm kind of favoring metastasis-directed as the early intervention, knowing I have a backup in my hip pocket that I can pull out if I need to.
Yeah, I guess like the unknown to all of that is like our endpoints of Oriole and STOMP. I totally agree. And I think like the big shift that's happened with all interventions for BCR is we took interventions for BCR and all of the previous, even EMBARK, where it was like 5 to 20 was the PSA where we were intervening patients, and we've shifted them all to 0.5 to 1. That's a huge shift on like when do you start intervention? Like what year are you starting intervention? Are you starting at age 70 or are you starting at age 78? That's a giant difference. And how many times are you doing metastasis-directed therapy? And so as long as like the only studies we have to guide us start to tell us, well, the time to PSA recurrence is better if you do metastasis-directed therapy, or the time to initiating ADT is better if you do something versus don't do something. I just don't think we have anything definitive there, and we have the ability to be more patient. That being said, I acknowledge there's different viewpoints on that one.
Yeah. No, and I think we could talk about this all day. We don't have that much time left, but I want to go to Dr. Kaufman's talk, which was really provocative. I mean, you've spent a lot of time thinking about this, and I was actually surprised at your cost estimate. I wrote it down. It was $43 per claim denial. My God, when you get a physician on the phone and you got to prepare and pull all that crap together and then go talk, is that really $43? It seems much higher to me. And I want to bill the insurance for the time I spent overcoming their denials. How can I bill them for dealing with their denials?
So,
I really want to know.
Yeah, thank you for that in-depth look. That's what the data shows. But the thing is, like personally, if I actually have a peer-to-peer, right? I have my nurse interrupt me when I'm seeing patients, jump out, talk on the phone, and it's usually, that's fine. First question is, you get my note? And they say, no. I say, okay, let me just update you on what's going on. And they say, oh, that sounds fine. Because remember, their algorithm is just to deny it and see if you bother to actually get on the phone and take care of the patient. Now, with the nurse navigation codes, I hadn't thought about this, so I put this talk together. That's part of nurse navigation. There are codes for that. So you have people in your office or in your practice, maybe, I mean, Albany Medical Center doesn't believe in it, so we're kind of, they want us to do better, but they can't give us the help. Maybe it's the same where you are, but I know that progressive LUPA groups have nurse navigators, are using the codes, and I'm sure they're achieving the goal, which is to make the insurance company pay for your time or your practice's time because it's a burden. It's just one more burden that's thrown on us we shouldn't have to deal with.
Yeah, Ron, great job with that talk. I know that wasn't an easy one. I hope you get to reuse it in other forums. We looked at this initially, and it was a staggering number of denials at our place. So we had a task force look at it. We're piloting a trial of we're in EPICS, we're using a dot phrase, dot PSMA prostate, just to be sure the notes have a very clear documentation trail that doesn't get overlooked. I don't know if that's going to fix anything, but that's our low-lying fruit approach. Do the moderators want any just quick comments or summations you want to make?
No, I mean, I think it's just a summary here is that obviously the utility of PSMA is there. I think it's only going to expand. The question ultimately is that how close to the microscope do we really need to get? Is it necessary to get? Do we want to get there? And I think we're going to start highlighting the differences between PSMA scans, understanding the biology, the tumors, et cetera. Again, very exciting space that's really redefining how we treat people. And we'll see, hopefully, the long-term benefits.